To you.
Turn off the radio.
Okay, thank you very much, Ian. Hello, everyone. My name is Jonathan Hazan. I'm Chair of Patient Safety Learning, where we believe that patient safety should be a core priority of a core purpose of healthcare, rather than just a priority to be traded off against a number of others. We also recognise that staff safety is absolutely crucial to patient safety, because without staff there can be no healthcare. And procurement is also a key part of patient safety as well. It's something that hasn't really been explored very widely in the past, but we're hoping to change that with this webinar, Challenges in Healthcare Supply Chain and Patient and Staff Safety. I just need to let people know that we will be recording this webinar, so if you don't want to appear, please turn your video off. And if I could remind everyone to keep their microphones muted as well, and particularly the speakers when they're not speaking. If you have any questions, then please type them into the MS Teams chat, and I'll get round to them at the end of each talk. We hope to have about 5 minutes at the end of each presentation to run through the questions. So thank you very much, everyone, for coming. And I'm now going to hand over to our first speaker, who is Jodie Chapman, Customer Engagement Director of NHS Supply Chain. So over to you, Jodie.
Thank you, Jonathan. For those of you who don't know me, I am, as Jonathan quite rightly said, Customer Engagement Director at NHS Supply Chain. I've been asked to speak on behalf of Heather Tierney-Moore, who's unfortunately can't make it today. Could you share my slides? Thank you very much, Charlie. Just wait for them to load. So whilst they're loading, this morning we want to explore different aspects of patient safety thinking about healthcare products and about patient safety within the NHS. We understand that healthcare is very high risk, and we're dealing with very complex systems and very vulnerable people and things that are evolving all the time in terms of complex clinical treatments and products. I think we're gaining more and more of an understanding in terms of the importance of the safety culture, and the fact that we're having this conversation this morning shows that more and more people in healthcare want to talk about this issue. And as part of this, I think is about shifting our focus away from just looking at individuals and their behaviours, but looking also at the systems of care and organisation of care. Can you move to the next slide, please? Thank you. I'm going to get rid of this. There you go. Somebody's got rid of it anyway for me. I'm going to start this presentation by telling you about NHS Supply Chain. We're part of the NHS family, and we manage the sourcing, the delivery, supply of healthcare products, services and food for the NHS and healthcare organisations across England and into Wales. We're managing more than 8 million orders per year. That's over 94,000 order points and over 17,000 locations. And we deliver more than 28 million lines of picked goods into the NHS annually, and our systems consolidate orders from over 930 suppliers. So quite a big unit. This enables us to bring value to our customers, including NHS savings and time and money to remove duplication of overlapping contracts.
That's amazing.
Could you move on to the next slide, please?
And a good thing, because you went on to leave.
I think you've skipped a couple of slides, unfortunately. The next one should be patient safety.
I don't know. It's a hard one.
Okay. Well, we will roll with it. So. Supporting the patient safety agenda. Everything that we do is rooted in patient safety, and because this patient should be able to expect technical competence and excellence care whenever they interface with healthcare, regardless of what that setting looks like. Next slide, please. Okay. So the importance of this issue is recognised within the NHS. And the NHS Patient Safety Strategy, which has 3 strategic aims. The first one being insight, the second involvement, and the third improvement. So improving the understanding of safety by drawing intelligence from multiple sources of patient safety and innovation is the insight. Number 2, equipping patients, staff and partners with the skills and opportunities to improve patient safety throughout the whole system is involvement, and designing and supporting programmes that deliver effective and sustainable change in the most important areas, which is improvement. Next slide, please. So with an even greater eye on patient safety, this is how supply chain works to support this agenda. We prioritise safety, quality and assurance. We use clinical and end user input and the essential specifications built by CAPA. We support the introduction of new technology and innovation into the UK, and we provide clinical engagement and product support, which shares best practice through our network of CNAs. Next slide, please. So before we move on in this presentation, I think it would be amiss not to talk about COVID and the lessons that we have learnt over the past couple of years about how we need to foster safety within our workings. COVID demonstrated how we can change within the NHS very, very quickly in an emergency. We had to introduce new ways of working, including a better use of video conferencing systems and increasingly thinking in a broader way of how we interact and work in partnerships. It's also highlighted some of the threats and potential fragilities in terms of patient quality of care. The management of infection prevention and control has become everybody's business, with personal protective equipment, physical distancing and other safety requirements necessary to prevent the spread of the virus within healthcare settings and into the community. The toll wrought on the NHS workforce by the demands of the pandemic have also presented risks to patient safety issues, with concerns about absence rates, staff burnout all across the NHS systems. Next slide, please. Our role in the NHS supply chain is to make it easier for trusts to procure safely by reducing the local burden and freeing up staff time for frontline care. And I want to point out that health and care professionals, those people who interact directly with patients, are involved across the whole procurement process, from strategies to product selection. Next slide. Because we want to make sure that the end result of this work is that we should have the products that are fit for purpose, easy to use, have safety when they're designed in mind, have proven effectiveness, and importantly, contribute positively to patient experience and in terms of comfort and helping to avoid unnecessary interventions or transitions into other or additional care settings. Next slide, please. So how do we get to that point? Well, we ensure that the NHS has access to the safest, highest quality products. First of all, we work closely with NHS care providers and other key partners across the health and care social system to make sure that they have input into product specifications, designs, and which includes quality and safety assurance processes, the product procurement processes, and a key part of which is that we prioritise patient safety. Next slide, please. We have the clinical and product assurance team, who you will know as CAPA. Our CAPA team is key to ensuring that all the products that we supply are of good quality, are safe and meet the needs and preferences of our product end users. The CAPA team ensures that the end-to-end process is widely informed by the right stakeholders who reflect the broad range of knowledge, skills and expertise across the health and social care system. The team is responsible for key areas of expertise, including the assurance framework, patient and user safety and innovation. So in short, CAPA is definitely a key part of product quality assurance, safety and innovation. Next slide, please. In addition to CAPA, we have a team of clinical nurse advisors are CNAs, who liaise directly with NHS Trust procurement departments and clinicians. They play a key role in ensuring clinical input is at the heart of the procurement process in order to deliver products that are fit for purpose, safe and value for money. This means we can make sure that the needs of health and care professionals are being met alongside those of the professionals and patients. Our CNAs advisors play a key role in determining the products that are available. Next slide, please. So our siren process. This process is for when things unfortunately go wrong. So for instance, in these current challenging times, you'll know that a disruption in the supply of medical products poses patient safety risk. And so the siren process is used to manage supply disruption issues. In that situation, we work with the Department of Health and Social Care, Nationally Supply Distribution Response Team. Crikey, that's a mouthful. And the next mouthful is NHS E&I Emergency Preparedness, Resilience and Response Team. I definitely had to read that from the script. And through this, we can mitigate the impact of supply disruption to the front line. This is one of a number of measures being taken by NHS supply chain to strengthen resilience around product and supply availability. Next slide, please. Another important component of the inclusion is the inclusion of human factor elements within the product specification requirements, and Colette Longstaff is going to be talking to you about this in more detail later on this morning. Next slide, please. An example of this approach is the introduction of new elastomeric device of a new elastomeric device at the Oxford University Hospitals NHS Foundation Trust. Intravenous antibiotic therapy is regularly given for a wide variety of moderate to severe infections. This is often given as a bolus in hospital on a 4-hourly basis. And we wanted to investigate if there was a better way to deliver this treatment that is less onerous for the patient. So we worked with the clinical teams at the Trust to pilot a fresh fill elastomeric pump, which meant that the selected patients were able to have their IV antibiotics at home. And during this trial phase, which was run from December 2019 to September last year, 86 patients were discharged with the device, which released 1,143 bed days, which equated to over £360,000 worth of savings, and also those tangible benefits to the patients who can make it home as opposed to staying in hospital. Next slide, please. So this is some of the feedback that we were given by the Trust, and obviously the clinical input into this pilot was absolutely critical to the success, and in making sure that the clinical teams using them felt that the new product worked and was safe. But also to make sure that the patient's voice was heard. By speaking to those patients who took part in the trial, we received really positive feedback from them, and most of them told us that the device was comfortable and did not restrict their daily activities, and most would said that they would use the device again. Next slide, please. So I hope this has given you an overview of the collaborative approach NHS supply chain takes in ensuring products are safe and make positive differences in the care of patients. And I hope that you enjoy the rest of this morning's presentations. And a big thank you to you for bearing with me while the dogs were jumping up at me. They were barking outside and were generally being rapscallions and making me miss my words. So thank you very much for your patience in all of that. Do you have any questions?
Thank you very much, Jodie. I didn't hear any dogs, unfortunately.
Did you not?
No.
One's brought I kid you not, looks like half a tree into the house. So
dogs, of course, it's always fun on webinars to see that sort of thing. But thank you very much for that very informative presentation. It would be great to take questions. I'm not actually seeing the MS Teams chat window anywhere. Maybe it's just my program. Perhaps I don't know, Helen or someone else can see those questions and forward them to me. But in the meantime, it was great to hear you say at the beginning of the presentation that there's a moving away from a focus on individuals to system issues and problems. outcomes, which is
Absolutely.
exactly how it should be. Could you maybe just say a little bit about what prompted that?
I think it's, as I said during the presentation, COVID definitely taught us some lessons. It definitely taught us that that there were some really good things that we did, but also some areas that maybe we needed to shine a light on and concentrate on. It has also refocused our attention on patient outcomes, and which are linked to safety. If all of us are here not working towards safe patient outcomes, then there's a question mark in my head around what is it that we're doing on a day-to-day basis. Helen, you've got your hand up.
Yes, Helen.
I can see the questions in the chat.
Okay, do you want
on the basis, Jonathan, that you can't, maybe I should read one out for you?
Yes, please.
Is that all right? This is from Margaret Scott, and she asks, are the elastrometric devices available to all trusts?
Tracy and Colette, could you help me with that? Are elastomeric devices available in all trusts? They weren't available in the trust that I was in, and I would have loved a device that enabled me to go home, but I'll ask my two colleagues.
I believe that there was a process recently undertaken around our innovation route around the introduction of those. So I know that there has been work on that to get them on the frameworks, but I'd have to check to officially let everyone know whether they're available for the NHS widely. So I can do that.
Thank you.
So Helen, are there any more questions?
None in the chat, but I've got one, which is a hard one.
Oh gosh.
If I may. Well, it's just, and I know Tracy and Colette will talk about this. You recognise the importance of culture, but I mean, how are you able to assess as a supply chain what contribution you're making to that culture change? I mean, it's a tough one to ask and a tougher one to answer, but.
It is. I'll go first, and then Tracy and Colette will go afterwards and correct everything that I've said, and put me back in my box. I would say that is really difficult to measure, but I think that it starts for me in the fundamental question which should be asked of us as NHS supply chain in our daily activity. How is this benefiting our patient? And if you can't answer in a positive manner in regards to our safety processes, our decision-making processes around innovation, then we are not doing our job effectively and giving back to the system as we should be. I will let Tracy and Colette put me back in my box right now.
I think you're right, Jodie. So supply chain is definitely been on a bit of a journey, and I think there is a recognition that that we alluded to earlier on, that it's not just frontline staff that look after patients that have the priority focus on safety. Actually, patient and end user safety at work should be part of the DNA of every single part of the system. And I suppose for every part of the system, then the question you need to ask yourself is, so what does this mean for us? And so why does this matter? And it goes back to Jodie's point about fundamentally the NHS constitution is about high quality, safe patient care, free at the point of delivery. And no matter where you work within the NHS, we all contribute to that, whether you're frontline, whether you work in finance, whether you work in estates, we all contribute. So we all have to take that mindset. And I think certainly supply chain, we are on a bit of a journey, but it's definitely moving in that it's not just about buying and selling stuff, it's really about that system response to making sure we're all doing our bit. So I'll get off my high horse now. Colette, have you got anything more to add?
Yeah, no, it's a difficult one about how we'll measure it at the moment. I think I've realised this year that although we all thought in CAPA that it'd be nice to change the world in the next year or two, I think through that process I've realised that it is very small, bite-sized little steps that we need to take to achieve that. So I think in terms of culture, certainly in our interactions with trusts and our onus on specifically around products and users, we're very much focused on use error now, and as opposed to user error. And we, you know, hopefully through our engagement and ongoing sort of interactions with trusts, particularly through the complaints and quality and safety processes, we can begin to sort of increasingly get that message across that it is around that, and that, you know, we're not interested in, you know, why someone, well, we're not interested in blaming the user. We want to understand why that product, sort of what contributed to that person not doing or providing harm or that was unintended, and we want to understand how the you know, perhaps the design of some of our equipments and technology perhaps contributed to that.
I know it's not really answered your question, Helen, but I was mulling over what it is that we were saying, and I would say for the first time, so I joined NHS Supply Chain in July, and for the first time ever, when we were starting to write out what our, you know, what was our strategy and what was our vision moving forward into this next year, for the first time ever, every single person that was part of designing that started to ask about, actually, how can we affect patient outcomes? How can we empower clinicians to be able to make the choice that they want to make to better patient outcomes? And that, to me, signals a big shift in our culture. Measuring it is the next step of that hurdle.
Okay, that's great. Thank you very much, Jodie and everyone. We're going to move on to our panel discussion now, and we have 5 panelists: Helen, Caroline, Janine and Tracy, and I'm going to ask each of them to give a 5-minute introduction first, and then we'll move on to a Q&A session. So Helen, if you'd like to kick off, please.
Thank you very much, Jonathan, and I heartily expect colleagues from the supply chain to ask me difficult questions afterwards. So yes, I'm Chief Exec of Patient Safety Learning, charity and independent voice for patient safety. And Jonathan's done a little bit of an introduction, but we do think that healthcare does need to be transformed in order to realise that ambition that Tracy outlined so beautifully about putting patient safety at the core of everything we do, and ensuring that we have patient and staff safety. So not just responding to harm and understanding the causes of the harm, but actually designing healthcare to be safer for patients and staff. And I think procurement is a hugely important contribution to that, and that system thinking about healthcare that we need. So I just want to, we wrote a little blog to contribute to this webinar. Many of you will have seen it, and I just wanted to highlight just 3 areas that we thought were worth exploring. And I know more expert colleagues like Chris and others later in the day will be able to expand in more detail. But I just wanted to look at 3 areas. One is the introduction of new products and technologies. How are we doing that, and how are we doing that safely, and are we doing that safely enough? And HCIB recently have, well, they've done a number of investigations, but the one that we highlighted was the risks of introducing infusion pumps and needing to do that safely. So it isn't just the design of products, it's safety in use as an important part of what we do. Secondly, in linking that and user-centric design, it's how we anticipate what safety looks like for users. And you've talked about not safety in use. So we gave an example in the blog, a quite humorous one, but of a very short, physically short surgeon, a woman surgeon that has to stand on a set to do surgery, because the theatre is designed for average 5'10" men and surgeons with large hands. So, you know, there are safety issues if you're not designing products to meet the needs of the users. And I think quite recently, it's only the last couple of days, a nurse in the US has been found guilty of causing harm in her interrelationship with an automated dispensing cabinet. So there are some significant, and Jonathan's shaking his head. I think it's it's quite a shocking case, and I hope that the response by prosecuting nurses that are involved in safety issues and avoidable harm is not. We're not responding to that in this country. There is MHRI guidance on procurement and design, but I think we need to do more to better understand and mitigate those risks. And then from a patient perspective, I think patients they're at the heart of everything we do, but their insight and learning can be invaluable. And those of you that will have read the Cumberledge report on mesh, sodium valproate and Primodos will know that the opportunity to listen and learn from patients' experience over decades was missed, and that really patient-reported outcome measures as a formal way of assessing and measuring and informing of the safety of products is invaluable. So I've just highlighted a few areas that I think our discussion could explore, and I have done a huge plug for the Hub, our learning platform. I put that in the chat for those that can see it, and we've got lots of content on there, and we always want to share good practice, so do please register for that and kind of learn and contribute to that. So
thank you very much. Thank you very much, Helen. I'm going to pass over now to Caroline Beecham, Commercial and Distribution Director at BD. Over to you now, Caroline.
Thank you, Jonathan, and good morning to all of you. As Jonathan said, my name is Caroline Beecham. I am the Commercial and Distribution Director in the UK and Ireland for BD. And I'm very thankful that you've given me the opportunity to come and speak. I suppose for the introduction, just wanted to give you a little bit of background on the BD supply chain, and then tell you what I can contribute, hopefully, to this discussion today. So, as in many of the global companies, our supply chain is organized globally. It's a central organization, so within the company, I sit at the end bit of our piece and the interface with you all in the NHS. We produce our goods in about 80 manufacturing sites around the globe, in about 20 countries. 18 of those manufacturing sites are in Europe. We have 70 odd distribution centers around the world. And use 24 in-house sterilization facilities, plus then a lot of contracted sterilizers. We have around 50,000 products globally. Not all of them are sold in the UK, but globally we ship about 8 billion order lines every year, and that would translate into 35 billion individual pieces or products of some kind. Now, I will say this is not unusual for a global company, and BD is by no means the only company that is organized in that way and has that size. So we are one of the largest suppliers to the NHS. And yeah, I guess the reason why I've been asked to come and maybe give a bit of input from industry is to just explain a little bit how supply chain works, what the challenges are right now at the moment for us, and what the impact of those supply chain challenges can be on patient safety. And then I could
I kind of wanted to, so that when I say like, what?
I think someone needs to mute their microphone, please.
I wasn't aware I had that impact. I'm slightly worried now.
That's great.
And then the last point, maybe, you know, what can we do actually to improve on supply chain matters, on patient safety, and how can we work closer together? I quite liked what my predecessor said about the NHS family. So we're not part of the NHS, of course, but we would like to do our bit. You know, we're part of a supply chain. We can't really do without each other. And so it would be nice to to be seen as an extended relative and working together with you. So these are the topics that I can speak to. I won't do that now, but later maybe in the discussion, if there are questions around those topics, I'll be more than happy to reply to them. Thank you.
That's great. Thank you very much, Caroline. I'm sure we'll return to that as part of the panel discussion. So next up we have Janine Jolly, Deputy Director, Benefit Risk Evaluation 2 of MHRA. Do you perhaps want to tell us a little bit about yourself and about that, please, Janine?
Hi, thank you, and thank you for inviting me to speak today. So as you may be aware, MHRA is currently transitioning to a new organisational structure. So I have recently taken on the role of Deputy Director, Benefit Risk Evaluation 2. Essentially what that means is that there are 10 therapeutic groups covering a range of medicines and medical devices in an integrated way. The safety and surveillance division that I am part of focuses on the post-market safety of medicines and medical devices. My teams will be responsible for assessing the continued benefit risk situation with medicines and medical devices to ensure that they remain favourable for deployment in the UK Health Service. And will be responsible for working with partners to mitigate any residual risks associated with medicines and medical devices. There is a strong element of involving patients and the public in those benefit risk evaluations to ensure that the patient voice is at the heart of everything that we do. The mention of the Independent Medicines and Medical Devices report has already been mentioned. And this was one of the signals, if you like, for changing the teams into this way. So as I've said, it's a new team. We are emerging. There will be a range of products that we will be looking at. We will be continuing to work in partnership with the wider health and social care system and our experts to be able to inform those benefit risk evaluation decisions.
That's great. Thank you very much, Janine. And then now over to Tracy Camish, please. Clinical Intelligence Lead, CAPA.
Yes, good. Thank you, Jonathan, and good morning, everyone. Thank you for this opportunity this morning. So yeah, my name is Tracy Camish. I'm Clinical Intelligence Lead and also head up patient safety on behalf of CAPA, which are within NHS supply chain. So my background is of a nurse. I have been a nurse for the past 3 decades. So very much in terms of product safety, I come to this role within supply chain very much of an end user, end user experience of products that have been supplied to us. In terms of the NHS supply chain remit and what we do within the patient safety arena, well, we've got 2 angles to how we deal with patient safety issues. We have a responsive approach, and we also have a proactive approach. So Jodie, in her opening conversation, talked about the volumes of the products that we supply and the diversity of the products that we supply, and subsequently, because of these volumes, we are going to get complaints, which is absolutely normal, and complaints are a good thing. Complaints are feedback. And going to Helen's point about Cumberledge, the key thing and a key driver for NHS supply chain moving forward is that we really are being proactive in how we listen to what people are saying. We learn and we respond to what end users are saying about the products that we are supplying. So our proactive response is that every single complaint that comes into supply chain is risk stratified by the patient safety team. And the reason we want to do that is to want to make sure that we absolutely identify if there is any potential risk or issue to end users or patients that have encountered our products. A lot of our products follow into the zero, so that goes through our normal complaints route. But we do have quite a high proportion of complaints that come through that actually do trigger what we call a containment response. And that means is anything that is scored 1 to 6 is within our low to moderate risk. And therefore, we then ask our towers to engage with the supplier of that product and come back with a solution of containing that issue within 72 hours. It's not to resolve the problem, but what we want to make sure is that our end users know that we're listening and that we're doing something about it, and we're engaging with our suppliers and getting them involved in that feedback, and to make sure that we mitigate any other problems happening. We also have a high risk. Anything scored above 8 to 25 is what we call our high to very high risk. And Jodie alluded to that earlier on when we talked about the siren response. And the siren is an acronym for safety intervention. And really this is as a call to action. So in the initial circumstances of a siren being called, we engage with our procurement partners, the relevant towers, the buyers, our inventory personnel, our supply chain personnel, and occasionally we will go out to the MHRA, NHS-E&I, and really very much make a triangulated response between procurement, supply, and inventory and our end customers, to make sure that we come up with an immediate response to mitigate any further risks happening. And we use the siren response as well, not only for when things go wrong, but also when we get wind that there might be some supply disruption issues coming through the pipeline. And again, it's really about, if we know something is happening and there is a risk that there might be a recall, then if we are able to prepare for that and the products are potentially recalled, or the products we cannot get a hold of, we have got a backup plan to make sure that continuity and consistency of patient care is maintained at the front line. And again, supply disruption is something that is becoming part of our business as usual. You know, Caroline will allude to this, but the supply disruption issues are very, very challenging, and there's multiple factors that are impacting on that. So again, supply disruption, working very closely with our supplier and manufacturing partners on a daily basis, with our colleagues at MHRA, NHS-E&I, is part and parcel of our patient safety and end user safety offer to the system, to try and do our bit to mitigate against patient safety.
That's great. Thank you very much, Tracy. I'm going to have to ask Helen to see if there are any questions in the chat, because I don't have the chat facility in my Microsoft Teams for some reason. Apologies. But Helen, are there any questions for the panel in the chat?
There are comments and there are questions. So I think there's a lot to kick us off. So I'm going to and Lindsay, who's later on, has raised a number of issues, but let me think which is the best one to start with. Well, there's one which is quite a technical one, and I've certainly got no answer to this, but do the panelists have any, this is from Jeff Best, do the panelists have any concerns with regard to lack of supply after July 23 if the products do not have UKCA mark, in part due to the insufficient capacity at UKABs? I can't explain all the detail of there, but I would expect
I can take that to start off with, if that is helpful. So it's a really good question in terms of the changes to the medical devices regulations and ongoing supply. So the first part of the question, in terms of the concerns, obviously we do understand that this is an area of concern for a lot of our stakeholders. People in the webinar will be aware that we recently closed a consultation regarding the UK medical devices regulations, and we are currently developing the public response to that consultation, and that is going through the necessary internal and external sign-off before that can be published. this is something that MHRA are acutely aware of, and we are working with a range of stakeholders to resolve that situation to ensure that there is adequate supply of medical devices on the UK market for post 2023. In my introduction, I mentioned that I've taken on this role in safety and surveillance, which is looking particularly at benefit risk evaluation. Colleagues who are familiar with the medical devices division as was need to be aware, or will perhaps be interested, is that division in its past form no longer exists. The MHRA is moving towards this integrated one agency medicines and medical devices approach. Former colleagues from the former medical devices division will be working in the healthcare quality and access division, which will be looking very much at that pre-market space, the bringing of products to market safely, to ensure that there are those supplies of particularly innovative devices and medicines on the UK market, and my team will be focused on ensuring their continued safety post-market deployment. So hopefully that goes some way to explain the situation.
Yes, thanks very much, Janine. Caroline, I think you wanted to come in here.
Yeah, just a couple of additional comments maybe from an industry point of view. So I share the concern, and everything you said, Janine, we are aware that there is a very high visibility of the UK CE mark question and how we actually implement that in the UK. I guess from an industry point of view, what we are getting somewhat worried about is that we get the heads up early enough to make the changes that are required. So it will depend a little bit if that UK CE mark has to go on the packaging of the product. And if that is the case, so I can tell you from the NHS Scan for Safety program where we put the GS1 barcoding on the packaging, that is not going to be a question of months. So if you have a vast variety of products, changing packaging and adhering to all the rules and regulations and registering those changed products accordingly will take time, and I think that is our biggest concern. And then the other point I wanted to make is that supply chain challenges we had a lot in the last 3 years, and I think this one around the change in regulation is one that is almost a leftover of Brexit, right? So we all forgot about that because we had our hands full with the pandemic, and it was said, oh yeah, Brexit, whatever, we dealt with that, and products are still coming across the border. But there are these more intricate remnants, shall I say, that are still ongoing behind the scenes and that need to be addressed.
Exactly. Thanks very much, Caroline. Tracy, did you want any input on this point?
No, I think the ladies have covered it.
Okay, thanks.
Yeah.
Helen, anything else?
I mean, I suppose what that just reinforces is the essential nature of the collaboration and communication between regulators, industry, suppliers, users, and as kind of evidenced by this kind of webinar, the closer that collaboration, the better, especially when you've got very complex changes that potentially could lead to risk issues for patients and staff. So, I'm kind of getting the sense that everyone recognises the value of that close collaboration, despite there being, commercial sensitivities in this. And I see from the nods that, I suppose the open question is that collaboration systematic enough? Is there more that can be done? Or do we think that the newer agents, particularly Janine, the ones that you mentioned at MHRA, once they're bedded in, they'll be enough? Given the complexity, I mean, just the sheer volume of products that Caroline was talking about, that's just gobsmacking in terms of the number. But, it's getting those collaborative arrangements across a whole range of supplies. Is there more to be done in this area?
I if that's a question to me, I think there's always more to be done in the area, isn't there, in terms of promoting partnership, working in close collaboration with the healthcare system. I mean, obviously the MHRA is the regulator for industry, so our regulatory levers in terms of the wider system, we rely on partnership working for that, in terms of the system ensuring that devices and medicines are deployed safely, and that any adverse incidents are reported to us in a timely manner, so that we are able to investigate that situation with industry and take timely action to protect patients and the public. I think the whole of the patient safety system, and you've mentioned this already, is entirely dependent on everybody stepping up to the plate and playing their part in a way that's open and transparent and has integrity. And if any one of those kind of moving plates slips, then that's where we have that kind of cultural classic patient safety Swiss cheese kind of issue begins to kind of develop. I think what the incoming regulations will mean is that it gives us that opportunity to really put patient safety at the heart of what we do, and the patient voice at the heart of what we do, so that we can ensure, and this is what we grapple with all the time in terms of making benefit risk evaluations, particularly with medical devices, is that you may have a medical device that is less than perfect in an ideal world. However, the removal of that device and not having that device available to patients actually presents a far greater risk to patient safety and health outcomes. And that's something that me and my team have to grapple with all the time to ensure that those benefit risk ratios remain favourable. And we can only really do that with the input and participation of our wider stakeholder group.
Thanks, Janine. It's very encouraging to hear such an emphasis on patient safety from the MHRA. Helen, can I ask you to take over for a couple of minutes? I think I need to log out of Teams so that I can resolve this problem, because I really do need to see the chat. So I can just ask you to take over for a couple of minutes, and I will be back very shortly. Thank you.
Will do. Okay, thanks, Jonathan. I've got there's a well, it's a sort of comment, but I think it's a comment that's worthy of other people reflecting and responding to, and it's from Sarah Jennings. She says, whilst education and training is always needed, providing users with devices that are designed in such a way that error in use is minimized through evaluating use, who the users are and the environment of use, is much more robust in supporting a safety system. So she seems to be focusing in, rightly in my view, that it's about that kind of design for safety rather than trying to train the opportunity for error out. So I think that would be worthy of all of us commenting, but maybe Tracy, you first, then Caroline, then Janine, and then maybe I can comment on that one as well.
Yeah, so I mean, Sarah's absolutely right. And that's, I suppose this is where the NHS supply chain essential specification programme has really is our flagship to try and design safety as part of our procurement, design safety into our procurement activities. So, and Colette will talk a little bit more about this later on, but moving forward as part of our essential specification programme of work is what we're doing is all new products that are coming up for reprocurement. What we're actually looking at is, in terms of the specification for those products, is it's not just about does it have the right ISO standard, does it meet the regulatory compliance, does it have we really want to get into the detail of where is this product going to be used, who's going to be using it, what environment is going to be used, what patients are going to be used on, what are the technical requirements of this product, how does it need to look, how does it need to feel, because the human factor element of this is absolutely huge. And it's not about reducing the amount of supplies, it's about reducing the variation in products that do the same thing. But actually, if we have issues around, for example, supply resilience, and we have a recall or we have a stock out, if we have a number of suppliers that are able to provide us with products that look the same, feel the same, are designed the same, that interact the same way, then actually when it hits the front line, it shouldn't be an issue, and it shouldn't be such a massive impact on that end user to use that product. And I don't know how many times I've given myself needle stick injuries because they've changed lancets over, for example. Lancet does what it does, but if I activate it a different way and I'm not shown how to activate it, then I'm going to give myself a needle stick injury. So it's down to those little intricacies, you know, and really understanding how it feels in the front line, listening to what is required at the front line, and then manufacturing that as part of that essential specification when we're going out to reprocure. So as I, you know, this is a large piece of work that Colette's been undertaking, and it's something that supply chain we're really proud of. It's a lot of work, but it's the right thing to do moving forward, so we can provide that level of reassurance to the front line that the products that if we're going to have to give you an alternative, it's going to be similar, and it's going to work the same, and it's going to do the same thing you need to do, and it's going to have the same output for your patients.
Thank you, Tracy. Jonathan, can you access the messages now? Hey.
Yes, I can see new chat messages now, but none of the history. So
Okay.
You might.
So I asked Sarah's question about
Please,
focusing on design and rather than sort of trying to train error out, designing it in, and I suggested that we would respond to that kind of statement rather than a question, but that Tracy and then Caroline, Janine, and then myself, and then I can hand over back to you at the end of that.
Okay, thanks, Helen. So over to Caroline, please.
Thank you. Yes, and Tracy, I agree with everything you said. You know, it is about designing, in the design phase of a product, to think about what can we do with this product to ensure that the possibility of error, shall we say, is as small as possible. But I think, and I think also very good what you said about really getting to the front line and understanding what are actually the problems that the users of the products encounter. You know, what are the problems that we're actually trying to solve and helping to solve is really key. If I can make one additional point, it's, I think, around the system as a whole. So, you know, we know that humans are very good at certain things, and, you know, machines will probably never be able to take that over. But then there are things where I think more automation could be beneficial, and that is, you know, the same in any environment, I suppose. Especially now with the COVID backlog, addressing that, still having a lot of COVID patients that put the system as a whole, I think, under enormous strain still, and placing a lot of demands on the staff on the wards that are looking after people. That's an environment that becomes very quickly very stressful. And stress, we all know, will impact on a human's performance. So if we can help look at solutions which will make life easier for those on the front line, that takes some of the things over and automates them so that they get a bit of headspace to really focus on the important things that humans are better in doing, then I think that that would also help a lot. And I mean, that's the same whether you work in an office or on the front line. If you get stressed, your performance dips. The trouble is on the front line, of course, when you deal with very sick patients, the outcome of mistakes can obviously be a lot worse than somebody just typing a few wrong numbers into a system. So I think it is really about thinking individual products, but then also, you know, what can we do to give some relief to humans in the system? You know, what are the things we could automate?
Okay, that's great. Thanks very much, Caroline. Who's next, Helen? Is it you?
It was Janine and then me.
Oh, Janine, and then you.
Yeah,
Okay,
it's me.
sorry.
I mean, obviously, I think to add to that, the human factors, designing in good human factors in the pre-market phase is obviously essential. I don't think I need to repeat that message. But I think also we need to think about once the post-deployment that the device is in use, the manufacturers post-market follow-up, their continuous clinical evaluation can also help get to grips with some of those perhaps less than optimum design challenges with medical devices, and that is where the role of the manufacturer's field safety corrective actions can obviously come in terms of mitigating those residual risks associated with devices in use. But it is no substitute for ensuring that good human factors design is integrated from the get-go.
Thanks, Janine. And back to you, Helen.
Yeah, so I'm going to pick up on that aspect, looking at it from the kind of patient's perspective, and give an example of a group of women that we've been working with, and it's the procedure that's outpatient hysteroscopy, and we know that 30% of women that have this outpatient procedure experience pain scores of 7 out of 10 or more. Now, there's nothing inherently wrong with the products, but it's how it's deployed in a clinical setting and the training of clinicians. And despite this becoming quite evident from patient testimonies and research, it's very difficult to try and get the health system to respond in the way that we would want, and the way the Royal College of Obs and Gynae has got very, very detailed guidance on this. And it's that interrelationship between the deployment of a comparatively new technology, which has been hugely beneficial to many women. It has reduced dependency on general anesthesia, which is good for patient risk, and it's an efficiency gain if you can do outpatient procedures rather than general anesthesia. It's a real benefit. But if it's not introduced in a safe way, then you've got this disparity of performance and inconsistency of performance that makes it very difficult for women to be able to guarantee that they know the risks, they can consent properly, and that they can actually stop the procedure safely when they're in extreme pain. And I think it is a good lens to look at how complex some of these issues are when you're introducing new technologies and the application of them, and how to get that information back. So, it's not a unsafe product necessarily, but it's not being applied in as safe a way. So who is responsible for trying to address that? And we find it quite difficult working with a campaigning group of women to try and get this issue highlighted and responded to, because we're working with a disparate number of providers, disparate number of settings. So I throw that out as a challenge that we haven't yet worked out how to do this well in all circumstances. But I also want to, if you can indulge me one more, is to pick up something that Lindsay has put in the chat, which is about when these are introduced. How do we know that we're auditing them safely? So yes, we're kind of reliant very much on incident reporting when things go wrong or complaints. But are we auditing on the ground in a regular way? Is there an opportunity there, particularly when we're looking at training and competency? So that would be one thing to have a think about as well.
Okay, thanks very much, Helen. I think that's all we have time for in the panel session, but some very positive comments that I'm seeing now in the chat from various people. So thank you very much to each of the participants in the panel session. That was excellent. I'm going to move on now to our next presentation, which is presentation Q&A on the role of human factors in delivering safety in the supply chain. Obviously, human factors is a big thing that we think is very important in patient safety learning as well. So I'm going to pass on to Colette and Chris now. I think Chris is going to go first. Is that correct? Chris is chair of the Clinical Human Factors Group. So I'm going to pass over to him now. Thank you very much, Chris.
Thank you very much. And I think I'm going to get my slides loaded up centrally. Fab. So yes, so Colette and I are going to talk about the role of human factors in delivering safety in the supply chain. My bit comes first. I'm going to sort of throw out a challenge which may feel a little bit uncomfortable. I've got two hats on today. One is the chair of the Clinical Human Factors Group, which is a charity promoting safety for patients through embedding human factors in healthcare. And the other hat that I'm wearing is my clinician hat. I'm an anaesthetist, and I've worked as the chair of the medical equipment committee in our hospital with procurement. So I've been involved in all the purchasing of all the medical equipment over the last 12 years in our hospital. So I've got a fairly good handle on that. So we go on to the next slide. This is my car. And if I decide I want to buy a new car, I can go to a free website and I can find out which car is safest in a variety of domains. And that is on the next slide, which is the NCAP, the new car assessment program. And on the next slide, it tells me that if I want to buy the safest car, I can buy in this class, I can buy a Renault Megane. And that is the safest in a number of domains, but there's nothing to stop me, if I want to, buying a BMW. Although I know it's not as safe in those domains, I may want to buy it because it looks good, or it's got good acceleration, or it's got a really good service program. But when I'm buying it, I can choose the safest, and I know which it is because it's been independently assessed. And interestingly for me, I can also sit in this meeting and have it recorded and say that the Renault Megane is safer than the BMW without fear of being sued by BMW, because that information is out there and publicly available. So if we look at the next couple of slides, how is it for me in healthcare if I want to buy something like infusion devices, or on the next one, defibrillators? And that's where the role of human factors in delivering safety in the supply chain can come in. So if we go to the next slide, and maybe even the one after that. Yes, one after that, please. Human factors is, we hear it talked about a lot. It's a science, it's also a profession. And the aim of the science is to make it essentially as easy as possible for people to do the right thing, and as difficult as it can be or impossible to do the wrong thing. And when we're talking about design of medical equipment, if we look at the next slide, and this came up in the chat, there are various ways that we can optimize performance or optimize safety, and that's through design. We're talking about design of medical equipment, through putting barriers in to stop people doing the wrong thing with the medical equipment that they've got, through mitigations, which is when something's gone wrong, what can we do to rescue the situation? And finally, through the humans, the end users, we can train them, we can select them, we can give them instruction manuals. And it's been talked about a little bit in the last session, but the most effective way of improving safety is through design. And the least effective way is through training humans and giving them instruction manuals. That's not to say we don't need to train people, we absolutely do, but if we rely on that and then we put the end users, the humans in the system, back into a poorly designed system with suboptimally designed equipment, all that training will be for nothing. So if we go on to the next bit, the MHRA, Janine's here, so she'll recognise this, as many of you will. In 2017, this document said, I'll read it, a usability engineering process can and should be applied by device manufacturers in the identification, assessment and mitigation of potential patient and user safety risks, and also in the analysis of incidents that have occurred. And this is the important bit, I think, in order to identify learning and put into place corrective actions to improve device design. So these usability assessments are mandated. The earlier they're done, the more likely we are to get changes in design. If we look at the next slide, is what the Healthcare Safety Investigation Branch have said. They say that testing and evaluation criteria should be included as part of the selection methodology used in NHS procurement processes. And we're going to hear from Colette in a minute, and we heard a little bit earlier on, that's happening starting to happen at the NHS supply chain level. But that doesn't absolve everyone else here who's seeing this now and might see it later, manufacturers, for getting the design right. We can't just put it onto procurement. It's an important part, but if they can only procure what's out there being built. So I've got two real life examples. We'll go back to the previous one if we can. There are lots more examples, but the first one is syringe drivers. I've got £2 million to spend. These are true stories. £2 million to spend to replace all the infusion devices in my hospital. And we got down to a short list of 4. And does anybody watching know which one of those is the safest? Of course you don't. I do. But the only reason I do, there wasn't an NCAP website that I could go to. We had to organise our own NCAP assessment of these 4 devices with a usability expert. So I was able to choose the safest device for our hospital in a range of domains. None of the other 309 hospitals in the country have done that, to my knowledge, so they're all just buying on some other criteria. If we look at the next slide, the defibrillators, not long after I'd spoken at a similar event to this one, I was approached by an executive from a health board who was looking to spend £5 million replacing all the defibrillators in all their healthcare institutions. And they'd got to a short list of 2, and he asked me if there's any way we could find out which was the safest. And I said, not without paying for your own usability assessment. And I could put him in touch with an expert for that. I happen to know that one of the devices that he was looking at had already been assessed by an ergonomist for another hospital and found to be wanting in a number of domains, but that information wasn't in the public arena either, so he just had to make up his own choices. So I've got the answer to the 2 questions, which is the safest of the infusion devices, the 4 that I looked at, and which was the safest of the defibrillators. But everyone else is just having to choose on criteria other than safety and hope they choose lucky. I would love for manufacturers to make their usability assessments available to purchasers, and it's a standard question I've been asking for the last 10 years. Every time our hospital buys a new piece of kit, can we see your usability assessments, your human factors assessment? I'm getting a bit tired of being turned down each time. Ideally, they would be available to everyone. In an even more ideal world, we'd have an NCAP equivalent for all medical devices that are in the supply chain catalogue, but that's there's a million pieces in there. But we could start with a few, and I think that's hopefully what Colette is going to talk about in a minute. Is there anything else I need to say? I don't think so. The best time to start doing this would have been 15 years ago, and the second best time is now. So I'll pass on to Colette. And,
Thank you.
There we go.
Thank you very much for that. Passing straight over to Colette Longstaff now, Clinical and Product Assurance Kappa.
Hi there. Thank you for inviting me to talk today. And I'm leading on from Chris's presentation. Are you sharing my presentation? So while the presentation is coming up, so just introduce myself. So I'm Colette and I'm a clinical products insurance sat within the same team as Tracy of Kappa in NHS supply chain. And I'm a registered nurse by background and have been working with supply chain for the last 4 years. So I've got quite a long history, 3 decades as well, like Tracy, I hate to say it. But I have a background of community nursing, district nursing and tissue viability nursing, which seems to sit a long way from where I am now. So following on from what Chris is saying, what I would like to do is firstly sort of tell you about what we're doing in supply chain currently by trying to embed human factors into our specifications, and then perhaps at the end talk a little bit about where we'd like to get to relating to Chris's point. So if we can just start with the first slide, please, with the next one. I do feel like there's been, I've basically been able to wipe quite a lot of things of what I was planning to say at the introduction of this presentation, because obviously Jodie's been talking about, you know, what supply chain are aiming to do. Chris has already given us the definition around human factors, and Tracy's talked about our safety, quality and safety complaints process as well. But so stating the obvious, we know that medical device design can be a contributory factor to staff and patient safety, and we have identified this as well through our CAPA assurance and safety complaints process. What we do notice though within CAPA is that like a large number of safety and quality issues actually don't relate to the highly complex, perhaps highly regulated products, the type that Chris is talking about, that often they're around the high volume everyday consumables such as IV cannulas, syringes, blood lancets, gels, electrodes, to name but a few, and those that are involved with us, such as NHSI and MHRA, in terms of our collaborative sort of investigation around those, will all recognise those and just think, ooh, yes. So so often it is about the high use consumables that do have certainly much less regulation. And so we've identified that there is a sort of real move towards identifying that there's things we can do around safety that sits beyond the regulatory processes that sit out there. Nevertheless, even though often it's around those high volume products, we still know that they've got the impact to cause unintended serious patient harm and even death, and obviously having a traumatic impact on patients, families, and healthcare users that are involved. So we know that there's further data that supports what we know from the NRLS system, and in the years of 2019 to 20, we know that there was over 54,000 incidents relating to medical devices and equipment that was reported. And the reason for this, I think we've probably already discussed in terms of, you know, we know that the healthcare system is highly complex. We know that there's evolving clinical treatments that are introduced at pace. There's busier care settings, and perhaps some of that care that you know traditionally has been provided in a quite highly supported acute environment is also moving across to less acute environments, including patient homes, which also has a contributory factor. So if we can move to the next slide, please. Every time I say that, I can't help but think about those daily reports we used to listen to a couple of years ago. Anyway, so in terms of, I'm sure all of you here will have seen the National Learning Report from HSIB, and this was really interesting in that it identified that 8 out of 22 of those incidents that they looked at were around the theme checking at the point of care, and some of that was related to devices. So this ranged, I mean, hopefully you'll be able to see there, ranging from sort of selecting surgical components to labelling and design of software. So as we spoke about, you know, some of these incidents were around being able to see if oxygen was flowing in relation to the portable oxygen cylinders, sorry, to sort of to the design of vaginal swabs, which made those swabs unlikely to be able to be detected if they were retained. Interestingly, just as an add-on to this, and Helen will perhaps be happy that I'm mentioning this, is the other area that was identified was around the assurance process around alerts relating to these products and safety incidents, and it certainly is something that jointly and as a system we need to be considering how we make sure that these alerts reach the right people that are actually using the products, because we do know that, you know, that these alerts are disseminated, but perhaps, you know, do not get to the people that are actually using those on the front line in the way that they're intended to. Can I have the next slide, please? So we've already talked about there's a system-wide responsibility to work together to ensure products, device and technology meet the end users. And by that, what we mean is, well, what we know is that error occurs often when designs are confusing, when there's lack of standardization, and basically failing to meet the user needs, and being able to be used perhaps in an appropriate situation, in an appropriate way. So we know that bad designs are as a result of not thinking adequately about those end user needs. And to quote the Clinical Human Factors Group, we know that procurement provides this unique opportunity to prevent the introduction of poorly designed products, but also in relation to what Janine has already mentioned, it also provides an opportunity to continually sort of give a feedback loop for suppliers and manufacturers to be able to continually improve the safety around those products. So can I have the next slide, please? So this is what we're trying to do, which is in supply chain, which is really why I've been asked to talk to you today. So the design of essential specifications really is around, it's building on our current assurance processes within CAPA. So those assurance processes are around like a framework level really approach to ensuring that the right stakeholders are engaged with, that the products are aligned to care pathways, that they facilitate the end users to be able to deliver that care in the most evidence-based way, that you know, any quality and safety issues are addressed. So in terms of essential specifications, they are focusing at a product level. So and what it is, it's a holistic due diligence approach, which is intended to change the way that we are procuring products. So the aim is that the specifications are co-designed with health and care professionals that actually use the products, and also with manufacturers and suppliers to not only specify the regulatory, safety, technical and physical specifications, but also including human factor principles and sustainability. Can I have the next slide, please? So this is the way, so we worked, just as a bit of a background, I can see that Joe's in in screen there. So what we did in CAPA, we commissioned some support from the Clinical Human Factors Group to not only provide us within CAPA around some education and training and some knowledge and skills that we needed, but also to try and identify a process that would help us prioritise our focus. So as you can, as Jodie's already said, you know, we provide hundreds of thousands of products in the NHS, and you know, we're a small team of 10, and we rely on the towers to undertake this engagement and to develop these specifications. So you know, in terms of resource, we really need to focus that on the highly you know, those high priority products that we've identified as requiring increased sort of safety focus. So the way we do that is we look at the capturing the relevant detail relating to the known users. Tracy's talked about the who uses them, who are they used on, you know, what environment are they used on, what physical environment are they used in, the task and the context of use. So we always capture that information around those products. We then prioritise the product risk, and my next slide looks at exactly how we do that. And then resulting from that, we then determine the level of human factors, engagement, involvement and specification required as part of that. So can we have the next slide? So this is, I'm sorry if this isn't very clear, but I will sort of talk my way through it. So So this is the way that we identify risk. So and it is all about that, you know, as we've talked about, that insight and understanding from safety information. So we look at the patient safety, human factor related complaints and quality issues that we've had for that product over the period of the previous framework. So we do this, and probably what I do need to say is we do this at the very beginning of the process around framework renewal, and for those frameworks that we've identified as high risk, this is sort of work is done 2 years before launch. So we're doing it this at a very sort of early stage to be able to engage and do what we need to do in terms of the specifications. So yeah, so we look at the safety risks, and we also look at any sort of national patient safety alerts that have been that the product perhaps has been related to. We also consider known hazards. So we know that you know, through our engagement, we need to be looking at asking the users of the products around any sort of workarounds that is undertaken to be able to use the products effectively. We know that nurses, perhaps all healthcare professionals, I don't know, are quite creative, and sometimes will use a product perhaps that in an unintended way, and not necessarily going to report on that. So that sort of insight comes through some engagement. And then we look at human factor red flags, which I can tell you about in more detail if you like, but it's certainly it's identifying those sort of high risk products around infusions, whether they're life supporting, etc. So once we've sort of risk assessed them, any red in that area. Oh, sorry, what I haven't said. So on the right is our mitigation control, and Chris has alluded to this. So you can see on this triangle, and this is something very much that Joe has sort of you know, helped us understand, that we know that you know that any sort of patient safety improvement through design is key. If we can eliminate all the risk and not use a unsafe product at all, then that's the best. Or we can substitute it for another product that is designed more effectively. But we know that the best type of hazard control is through design, as Chris has already said. And second to that is around procedures and instructions, so that administrative control, and then at the very bottom is protective equipment. So as we've said, you know, education and training, particularly around the introduction of equipment and technology, is massively important. However, what we do want to move away from is, you know, when I'll give you an example. So when you know, perhaps a product has been involved in a patient safety incident, sometimes in the past there has been a lot of emphasis on the user reading the instructions for use. And you know, we know that actually in a busy, highly pressurized environment, as we've talked already, that isn't always possible. Yes, you need the healthcare worker to know what they're doing with that piece of equipment, but actually, if it's a piece of equipment that isn't supplied by that, you know, we want a piece of equipment to be consistent. So whether it's you know, one piece of equipment provided by one manufacturer, we want to be consistent. Have a consistent design often with another manufacturer. So often we want users to be able to use a similar piece of equipment with the expected outcome of of the same, and not need to know how to use a piece of equipment basically because it's designed by another supplier. I hope that made sense. Can I have the next slide, please? So
Caroline, we're almost out of time. Sorry.
Sorry, very quickly then. So we are introducing the use of user and environmental profiles. So basically what this does, it helps us focus on the characteristics that are the most difficult to supply. And just around the environmental factors, what we discussed earlier was where we can identify the high pressure, urgent, unplanned, time critical situations. We also need to be focusing on those and the design of that equipment to help people to use them more safely. So if I could just have my last slide then, please. We can skip that because I think I've already said that. So my last slide is just to say that we all have a responsibility, don't we, to for this approach to design and patient safety. And basically this last slide, just in terms of clinical end users, about reporting safety incidents and engaging around the design of products, the NHS healthcare system, so the wider NHS, people in procurement in NHS trusts and safety officers, to suppliers and manufacturers. And I can't get over enough how we desperately want to work with suppliers and manufacturers and to be able to share that information, as Chris has alluded to. And again, our continued work with regulatory and national strategic partners, which has been undertaken already to help sort of design processes and systems where we can work together to improve patient safety. And that's me.
Brilliant. Thank you very much, Colette. That was really good. Just time for one question to Chris. What is the explanation as to why they, the manufacturers, I guess, won't share usability assessments, and how do we know that they do these at all or well enough?
So there's two answers to the why not share. And I've spoken to some of the ergonomists who work with some of the big companies to ask them. One is commercial sensitivity. They say that's commercially privileged information. And the other is that they've said to me privately is fear of litigation. They've turned up something in their use assessment, which they then have to put a mitigation in an instruction manual, which if they'd have known about it earlier, they would have changed the design. So commercial sensitivity and fear of litigation. How do we know that they do them at all? Someone from the MHRA is probably better placed to answer that. We know that they do them in certain situations because of the stuff that appears in field safety notices and in instruction manuals where they point out some of the use hazards of their devices.
That's great. Thank you very much, Chris and Colette. And now we're going to move over to Lindsay Keeley, Patient Safety and Quality Lead, AFPP, and followed by Alison Venn, Senior Clinical Consultant at BD. So over to you now, Lindsay.
Hi, thank you, Jonathan. Morning, everybody. Just a brief introduction. My name's Lindsay Keeley. I am the Patient Safety and Quality Lead for AFPP. I'm also a registered nurse with over 35 years experience in the perioperative practice and also a surgical first assistant. I'll be sharing this presentation with Alison Venn, who is a Senior Clinical Consultant for the north of the UK on infection prevention and biosurgery for BDI, UK and Ireland. So halfway through the presentation, I will hand over to Alison, just so you understand. The topic I was given was quite a long topic, as you can see from the presentation, and trying to get all the information in that you need. So it's basically, how are we going to protect patients and staff in perioperative care through better procurement and applying evidence-based infection prevention and control measures. So AFPP basically promotes high evidence-based standards on perioperative care, is sharing and engage and exchange professional information between perioperative practitioners and other professional bodies. The AFPP recognises that a multiple organisational collaborative approach in the prevention of surgical site infections is fundamental, an important aspect of perioperative care. It acknowledges that every member of the perioperative team is accountable and has a responsibility across the surgical pathway. So through evidence-based practice, AFPP continues to provide standards and recommendations to improve the surgical environment, protecting practitioners and promoting patient safety in the reduction of surgical site infection and hospital-acquired infections. AFPP also works collaboratively through the sharing of expert knowledge and evidence-based practice by engaging with professional organisations and our medical partners in industry to reduce the impact of surgical site infections. So the session objectives, as you can see, are to explain the importance of standards and guidance and recommendation, outline the significance of research evidence-based practice in infection prevention and control measures, describe how clinical teams can identify and inform and work collaboratively with procurement, and describe in this, one of the things that I was involved with was particularly around identifying certain products and things that I was using in practice, which I will talk about later on. Also identifying what theatre teams do and get involved with around procurement, and how it's important and key that these clinical people are involved in the process. This will also illustrate the benefits and the impact of clinical involvement and the support of practice, and also discuss the significance and importance of clinical engagement with procurement around the staff and patient safety issues. So one of the things that APP worked on was the Monoliki report, which was done a Time to Act report, which was produced in 2020, and I worked on this, looking at surgical site infections. So surgical site infections are still out there, they still continue. There still is a high incidence of 60% of surgical site infections which are preventable. This is meaning that more than 5 patients undergoing a surgical procedure will contract a surgical site infection, which is far too many, considering the implications to the NHS regarding costs on patient care afterwards, wound dressings, further surgery, etc. So it's important that we understand that this is still going on out there, and because we don't have any national guidance where everybody has to report as far as surgical surveillance is concerned, this is still continuing in practice. So one of the things I work at from a nurse is evidence-based guidance. So everything that I do has to be researched and evidence-based, and that's where I work from. And that's the only way that we can change practice and improve care and patient safety. So it's looking for the best evidence that's out there, looking at the type of evidence, how the evidence is collected, etc. Looking at where the sources are. So are these credible sources, such as like NICE guidance? And also looking at the patient's needs and values. Also looking at expertise, experience, skills and judgment. So this is from clinical people with experience and knowledge working in these particular fields. And the other thing to be aware of is looking at trust policies and procedures. So if we have certain evidence-based guidance that's there, we then need to have policies in place for us to work with that guidance to make sure that we're working with it in clinical practice, that it's mandated and it's maintained and then it's monitored and audited. The patient also needs to get involved in this as well, because they are key to also preventing and reducing a surgical site infection. Also, looking at the multidisciplinary team approach, everybody that works in healthcare is important. So your multidisciplinary also affects the theatre team. So the theatre team cannot do anything without other people that are in this team. So this is your path lab, procurement, pathology, it's x-ray. So everybody that gets involved in it. So you need a dedicated professionals, and all will have different specialities, different skills, different experience, which they need to bring to the table in around procurement, products that we use, etc., to support patient safety and reduce surgical site infections. Being able to identify the correct products, making sure that they're fit to use, they have the acquired trademarks on them. And then also introducing changes through good communication and education, which I mentioned earlier in some of my chats. It's important that obviously we're able to change products, you know, and provide products that are more suitable, and they may be cheaper as well and easier to get hold of. But equally, we need to provide the training and the education around that, and then be able to maintain that, go in, monitor it, etc., through audits, etc. One of the things that I found, which is very interesting, is this Small Changes a Big Difference campaign, which came out in 2021. And this basically highlighted the fact that healthcare professionals, not just nurses, but everybody who is involved in clinical practice, does have a part to play in actually reducing a surgical site infection and supporting the procurement team with regards to purchasing products and things that are fit to use. So small changes do actually make a big difference, which is what this is saying. I mentioned earlier about standards, guidance and recommendations. So there is numerous standards, guidance and recommendations out there for healthcare professionals, all of which we go to when we're looking at providing policies, training, protocols, changing practice, etc. And although these standards, guidance and recommendations are not legal requirements, They are research and evidence-based. So if we do not at least look at them, follow them and put them into practice, and something happens, then equally we will be judged in a court of law of why we didn't look at these and use these or put them into practice within our local trust. So AFPP provides evidence-based guidance in their standards and recommendations to disseminate best practice, enhance preventive practitioners' knowledge on preventing surgical site infections, particularly around skin preparation, hair removal, skin disinfection, maintaining asepsis and the surgical environment, surgical hand antisepsis and mood management. This is in the infection control and prevention section. Now, when you're looking at hair removal, it's important to understand that many years ago, we used to use big razors to shave patients' hair, often shaving hair when it wasn't necessarily needed to be removed, which NICE guidance identified, and equally using a device that actually caused more harm to the patient and potentially induced a surgical site infection. NICE brought some new guidance out in 2008, and I was currently going through some training at the time, and I went into my organisation, I removed all the razors, and I brought in basically another device that would hopefully support and reduce potential risk of surgical site infection, and also change the practice, able to put a policy in place. And this was due to the guidance that was out there and the research and the evidence base behind that, which supported any change that was required within practice. So this is why we need to look at all of these standards and guidance and use them, and then look at the research behind why these been put in place. AFPP works continually collaboratively with medical health suppliers, but also we work with other organisations. One of the big things that AFPP worked with was the One Together UK collaboration, which was on basically around everything to do with theatre, surgical skin preparation, patient warming, the environment, and all of these things potentially can induce or reduce a surgical site infection. But all of these areas all require products and equipment that are sourced through procurement. So it's important that people understand why we use what we use, when we use it. And this is why some of these toolkits were there to support people and also to provide them with the information that they need to reduce harm to a patient or potentially induce a surgical site infection through bad technique or not using the correct equipment at the right time during the surgical pathway. How can procurement prevent and control infection? So one of the biggies is PPE, which we're all aware about when COVID hit us back in March. And this basically was a massive issue, which we got a lot of healthcare professionals contacting us through the professional advice service at AFPP. All suddenly panicked, didn't seem to think about what their current practices were, weren't speaking to their infection control people, and suddenly running around like headless chickens. So basically what they needed to do was currently look at their infection control practice as it was, and the current PPE they were currently using. And having seen and worked in healthcare and still going in clinically, you could have as many as 5 different types of masks in an operating theatre in a scrub room, but they weren't actually used correctly. Often they were pulled apart. People didn't like the visor or they liked the colour purple. They weren't wearing the appropriate PPE for the actual job that they were actually doing. They were just doing it because they liked it. It suited them, or it felt comfortable. It did the job. And this is where I think procurement and healthcare professionals need to work together to source the correct equipment and use the evidence base behind it to support practice. So is the items a fit for purpose and can you use them? So this would also support and safeguard both patients and practitioners and provide educational training and also support local policies as well, which also the recommendations will support. The other thing, the concern with the mask was I had an issue where somebody was saying that suddenly we got from tie masks to loop masks, and somebody said to me that these were actually removed from the UK market because they were unsafe. Having actually used them predominantly previously using tied masks, the big issue was they hadn't actually been removed officially. It was that people didn't like using them or they had issues with them. So when you're actually speaking with the actual little loops on your ears, your mask moves up and down on your face. So when you're actually scrubbed in theatre, as you're speaking and having to talk through a surgical procedure, the mask would move and you weren't able to put the mask back on your face. So that was the main issue that they were causing. But then there's also been other devices brought in that will also help support tighten these elastic loops around the ear. So I think they are still in use, and people are still using them. I actually haven't seen any of the Thai masks about anywhere since I've been in clinical practice. Moving on to resources and procurement, this is a fine balance, hence the skills, which is, it's about us working together and using the resources and the clinical teams that are not only just working, you know, in practice, but those clinical people that are working in procurement. And it's how we achieve this fine balance with the resources that we've got in a more efficient way. And showing that the goods and the services, you know, that the NHS uses daily are procured in a way that delivers the best value for money, as well as retaining a high level of clinical assurance, reducing patient risks and promoting safety. So this is key again to reducing surgical site infections. The environment that we work in theatre is an extremely risky environment. It's very dangerous, and therefore we have to make sure that the environment we're in is clean. Appropriate policies need to be in place to do that. We have obviously reusable equipment and single-use equipment. So even the equipment and the furniture needs to be provided. So all of these things need to be considered when we get into BSI standards with regards to theatre equipment. The standard infection control precautions. So it's such a big topic and covers so many areas within theatre, but it's everything to do with what we wear, how we wear it, what's available to us. So hand hygiene, you know, not just your basic hand hygiene, but your surgical scrub technique in maintaining asepsis. All the PPE that you're using, which is your hats, your masks, your visors, your aprons, all of these things which became an issue during COVID and equally are still causing people some issues now, not knowing what to wear and when to wear it, and then being able to obtain the item that they need depending on where they're working. A big issue around donning and doffing technique of how to put your surgical gown on and remove it without obviously creating risk to yourself after surgical procedures. And equally, there's sterile instruments and devices and decontamination, which is a big part of theatre practice. So all of these potentially can induce risk and also induce infection risk, not only just for the patients, but for the staff. So we need to be aware of this. So reducing the risk of transmission. So it's important to know, as I've mentioned, about the hospital environment and the hand hygiene, but then it's also maintaining it, so providing training and education around that, providing the suitable equipment that they can use to support this. PPE again is a big issue. The safe use and disposal of sharps, which we mentioned earlier this morning, and then basic principles of asepsis that we need to maintain. So looking at the image above, you can see the red areas that are unsterile, and it's being able to maintain the green areas and asepsis during a surgical procedure, and then having the right products to do that, the training and education in order to support the use of those products, following instructions for use, which manufacturers provide. And as you can see with the lady on the right, she's got a mask on, she's got a visor on, she's got a gown on, and she's got gloves on. I've often seen practitioners working in the scrub setting and they're not wearing a visor. They think their glasses are suitable, so it's understanding that your glasses are not classed as PPE, and therefore you need to use the equipment that's being provided from the organisation. The other thing to remember is that all the equipment needs to follow the BSEN guidance depending on the equipment. So the BSEN 137951, which is 2019, which is for surgical clothing and drapes, that needs to be adhered to, and also single-use and reusable items need to be observed and checked for CE marking, which we've also talked about this morning. Best practice double gloving. This is often quite a topic that some people don't want to adhere to, but double gloving is the best practice, and having worked in healthcare and been exposed and used double gloving, I've actually seen within minutes that I've had strike through in a glove when performing major surgery, or it depends on the length of time of surgery that you're actually in, so like liver surgery, orthopedics particularly, and also the protection that you need in to protect you and the patient from potentially, again, inducing a surgical infection or putting yourself at risk. Again, these need to follow the BSEN 4551 standards, and the choice needs to be around the type of practice that you're doing and the type of surgical procedures that you are performing. training and education needed on this, and this needs to be embedded in practice. There also should be policies in place which I think are a bit hit and miss across various different trusts. There has been occasions where some people do triple glove, but that's by choice, and that again will depend particularly on the speciality that they're scrubbing for. The best practice for surgical gowns and drapes, as I've mentioned, must meet the BSE N 13795 standards, which I've said. The material should be closely woven, etc., that reduces transmission, and also needs to be waterproof. Fire retardant is a must, and resistant to wet and dry bacterial penetration. So particularly around this, the other thing you need to think about is trolleys and covers for trolleys. Trolleys, in order to maintain asepsis, need to have 2 layers of material over the trolley drapes, whichever one of them needs to be water repellent. No longer is one single cover suitable because you've got issues with strike through. The other thing we mentioned, management of sharps, incorrect use of venflons and cannulas. So again, this is training around all of this and issues around infection prevention for yourself and the patients, how to remove them, following the actual instructions for use, having some training on it. Often you see with the new safer cannulas, anaesthetists were ripping them apart in practice because they didn't like them, and therefore potentially putting themselves and other users at risk within that environment. So therefore, this is why you shouldn't be changing a product that has been designed for specific use. It's knowing how to get rid of these, where to source them. All of these things need to come from procurement and need to be supplied. So therefore, they need to be fit for purpose and be suitable to use. So minimize the risk of surgical site infections. As you can see, we need to follow the NICE guidance during and after surgical procedures in order to remove a surgical microorganisms and colonizing on the skin. This needs to be evidence-based, and we need to use antiseptic skin preparation that is fit for that purpose identified through NICE. We need to minimize any introduction of surgical site infections, and equally airborne particles, so that's reducing traffic within theatres, wearing the suitable theatre attire, and then also having policies in place to support this. Also regarding intraoperative skin antisepsis, we need to look at containers. So working in practice, you will often see large sort of bulk bottles, smaller bottles, depending on what type of surgery, and also we see applicators and devices. So one of the things to reduce harm and risk to patients, which I've seen in practice, is whenever you're using either bulk bottles or you're pouring fluids into a sterile container on the sterile field, you need to make sure that you're pouring a certain amount in there, that you're careful not to contaminate, and that equally that these bottles of antiseptic are within date and they're not expired and they're not contaminated in any way, as that can potentially cause another risk of a surgical site infection. You need to also be aware of where to store these suitably, and if that you're looking at the bottles, there'll also be instructions for use which are supplied by the supplier. One of the risks often seen is when you're pouring fluids into a gallipot on a sterile field, often some people leave these products on the sterile field rather than remove them, and there has been incidents where certain fluids have been injected into patients and caused never events. So if you are going to be using this type of process, then you need to make sure once you've followed the skin antiseptics that these fluids are removed from your trolley. Everything on your trolley should be labelled. There should be nothing on your trolley that you're using that is not labelled to reduce risk to the patient. So protecting patients from surgical site infections. So every patient matters. There is a potential for complications when it's a procedure, so we need to reduce the risk wherever possible. We need to encourage engagement and compliance. This is around products and training and infection strategies. Provide educational resources, which I mentioned earlier, and implement surgical care bundles in routine clinical practice, which are there. And one of the biggest things is to encourage patients to adopt an active participatory role in their surgical care. More and more, it is evident that the patient should be involved in their care and be part of the process in order to reduce the risk of them getting a surgical site infection. So a quote before I move on to Alison is, I thought this was quite interesting from Alexander Fleming. Basically, I play with microbes. There are, of course, many rules to this play, but when you have acquired knowledge and experience, it's very pleasant to break the rules and to be able to find something nobody has thought of. So I'm going to go over to Alison now.
Thank you very much, Lindsay. Over to Alison Venn now. Bear in mind we need to finish at 12 and leave a little bit of time for
I'll be quick. I'll be as quick as I can.
Great, thank you very much.
Thank you very much, Lindsay. Like I said, I'm a clinical consultant. I'm working with ChloroPrep as one of our products. So I thought, since we're looking at antiseptic skin preparation, just to say that patient safety is a really big focus of ours, and with the evidence to support it, such as we were just discussing there, or Lindsay was just discussing. If you wouldn't mind going on to the next one. These are just the basic information about ChloroPrep. So we know it's an optimum solution of 2% chlorhexidine gluconate and 70% isopropyl alcohol. It's the only licensed and commercially available applicator. There's two sizes for surgery, single-use sterile applicator, comes in clear or tinted, 3-year shelf life, no special storage. So when you look at, when you're choosing product, that's probably the information that you're looking at when you're deciding what it is that you're buying in and why. Next one, please, Lindsay. But perhaps some other bits that are really important, that are even possibly more important to do with surgical site infections, is to know that ChloroPrep has good activity levels within 30 seconds, which is really, really fast. And also that it's effective for at least 48 hours following surgery, which is a long time. People don't realise that when they have skin preparation, that it can continue working after the surgery. They think that it's just skin prep for the surgery on that particular day. Next slide. The other thing is that what else comes with the products that we supply. We've certainly spent a lot of time during COVID looking at what else we can do that we're able to help the healthcare setting with. So we've been looking at helping provide protocols for hospitals, but with the evidence that goes behind that. So looking at NICE and then giving them something that's really clear to see. So it's what NICE recommends: first line, second line, third line, fourth line. And it's not saying that ChloroPrep, our product, is the only product and that's the one that should be used. It's using what should be used in the correct order at the correct time with the right device. Next slide. Again, using evidence, NICE has said that that there is, in addition to patient health benefits, NICE economic analysis also showed that even using 4 ChloroPrep applicators per operation, it remained cost effective. So sometimes there's some thoughts that you really should only be using 1 or 2, which might be correct, but it's still cost effective at up to 4 per surgery. And that's the evidence that we're trying to give as well. Thanks, Lindsay. And it's not only the right product, but it's also how it's used. So we know that skin preparation can be given in a bottled solution. It can be prone to contamination. You can't tell quite often when a bottle has been opened, whether or not it's been opened. It's quite often not locked or sealed. Dripping and pooling, there's a risk of fire. Again, NICE identifies this as a risk. And the Gallipot safety that Lindsay alluded to, those 2 patient safety alerts, one in May 2015 and one in September 2016, both giving warnings from NHS England about the use of Gallipots and removing them before there's a knife to skin. Thank you, Lindsay. Next. Again, we've done quite a lot of work with Lindsay to do with fire safety for patients. Any kind of alcohol solution is flammable. So by using our product, it helps reduce that risk because the right amount of product can be used. Whereas if you're using a bottle solution, you can't measure how much you're using, and quite often they're in large bottles. If ChloroPrep is contraindicated, which it may be, really bottles should be used that single use. The information again about the Gallipots, double preparation isn't necessary. This disposal of bottle solution according to local policy, because there's a lot of product in a bottle for skin prep, whether or not there is actually policy available of how they get rid of that product. and then always check IFU on how to correctly use the bottle solution, because sometimes it isn't actually, it's classed as a biocide rather than a skin preparation. Next slide. So some of the things that we've done during COVID is we've really looked at how else we might be able to help help the healthcare environment. So we've looked at aligning with the individual's surgical site infection prevention bundle. We're planned pathway for introduction and policy development. And we really have a whole range, literally from going in and identifying what current practice is, doing a skin prep review, looking at standards that are currently happening in the theatre environment, making changes and identifying how the best way would be to do the training, and then reviewing again. So, you know, this evidence base that you've been talking about throughout the morning, I think we really have captured and had the opportunity to develop. So we do next slide, if you wouldn't mind. So we can now do virtual training. We do now have videos. We have online training certificates. We can still go in and do face-to-face if it's deemed as necessary. But there's just so much more now that we're able to offer to do with education. And I think it's really important for us to have aligned our training and literature and development with what is actually currently required within, you know, the hospitals themselves, and the individuals are struggling to be able to get education that's needed, that isn't paid for, and we're able to do that both face to face and virtually. Okay, thank you. Thank you, Lindsay.
Thanks, Alison. So I hope you've got some sort of information from this, and the guidance and the recommendations that are out there to support us in practice, but equally about us working together with procurement and healthcare professionals. It is a team. We are a multidisciplinary team, and we all need to work together to support each other within clinical practice. We do have a profound effect, depending on what we use, how we use it, training and education, and also putting patients at risk. So we need to be aware of how to reduce a surgical site infection, need to be focused on that. And equally to address any sort of interventional issues that we have and any challenges that we face, and be able to have a good form of communication across all the different teams in order to support each other, particularly when products are being changed, taken off the market, or there is a need to change a product due to evidence-based practice to improve patient care. Thank you very much, and I'll stop sharing now.
Thank you very much, Lindsay, and also Alison. I was really interesting to hear that presentation. Actually, I remember a few years ago, I think it was in 2014, watching a video about Gina's story at Doncaster and Bassetlaw, where a patient was undergoing an angiogram, and which unfortunately led to her leg being amputated as a result of chlorhexidine being injected instead of contrast dye because of the use of Gallipots in that situation. So that was really interesting. Thank you. So that was a excellent webinar. Thank you very much to all of the speakers and everyone who's taken the time to come and watch today. We've heard about the whole of the supply chain and patient safety all the way through, from the manufacturers to the end users, the clinicians who are going to be using the devices and products. It's really encouraging to hear about the importance of system issues moving away from individuals to systems. I think that's really encouraging. Everyone's talked about that. It's also great to hear the importance of human factors to basically everyone all the way along the supply chain. So I certainly think the situation's moved on from improved in a vast way from several years ago. Of course, there are still challenges, plenty of challenges with resources and workforce and time and so on. But you know, it is good to see how how people are taking the importance of patient safety and staff safety, and starting to see that really as a core purpose, and moving on from that being yet another priority that needs to be traded off amongst others. So thank you very much to everyone who's taken part today, and that's the end of our webinar. So goodbye, everyone.
Thank you.
Thank you.
Yeah, thanks. Bye.
Bye.